Good morning, everyone, and welcome to my presentation. It's a great pleasure to be among you today. I would like first to thank MSERM Congress organizers for this great event. Let me start by saying a few words about my own background and the structure I work in. So I am Hajar Ilal, an MD, resident trainee in the Hospital University of Fes. So I'm a resident in Genetics and Oncogenetics, Unit University of Fes, with the supervision of Professor Olde, Professor Gounosh, Dr. Amasdal, who supervised this study, as well as the rest of the team residents and PhDs. So as you can see on the screen, our topic today is genetic explorations of male infertility at the University Hospital Hassan II Fes. So our theory includes 117 patients collected in our department in the last 5 years. So during this presentation, I will in the first part review the standard genetic assessments in the etiological exploration of male infertility while presenting clinical cases diagnosed in our unit. And then the second part I will show the interest of the new diagnosis tools that will modify the management of couples and integrate genetics in the daily practice of MAP, medically assisted procreation. So as you all know, male infertility is defined by the absence of pregnancy over than 1 year. It interests 14% of couples worldwide, an average of 70 million people. So in more than half of infertility cases, the male factor is involved. 15 to 20 of the etiologies of non-syndromic male infertility are potentially genetic. So 82% of all human proteins have testicular expression. 11% of genes have 5 times higher expression in the testis than other tissues, which explains the genetic heterogeneity. So what is the place of genetic tests? Well, it's first to determine the cause of non-obstructive azoospermia, to adapt care and decisions concerning the type of medically assisted reproduction, for preventive measures for the preservation of fertility, and at last to inform the couple about the risk of transmission of a parental chromosomal abnormality, the risk of transmitting infertility, the choice of pre-implantation genetic diagnosis or prenatal diagnosis. So at this is the standard investigation workup of male infertility you all know, and that has been prescribed for over 30 years. So first we indicate classical karyotype. In case there is a discordance between clinical examination and karyotyping, we proceed to hybridization in situ by the SRY probe, or CFTR mutation by PCR sequencing if we suspect cystic fibrosis. So these tests that you all know have been prescribed for over 30 years. The first investigation is classical karyotype. Its results should be obviously correlated with the spermogram results. So in our theory, it was abnormal in 5% of patients with oligoasteroteratospermia and 10 to 15% patients with azoospermia. So in this table, we have multiple karyotype abnormalities described in the literature. So we have numerical as well as structural abnormalities. So the most frequent one is Klinefelter syndrome, 47XXY. Then the reciprocal and Robertsonian translocations between the Q arm of the pair 13 and 14. Then the structural abnormalities of Y chromosome, like ISO-Y, the deletion of Q arm, and the translocation of the Y chromosome on an autosomal pair. And last, we had a few cases of males that presented an XX formula. The sex diagnosis was done by hybridization in situ by SRY gene, which was positive. In this slide, you see the Robinsonian and reciprocal translocations. They form trivalent and tetravalent translocations that lead to an asynapsis at metaphase and stops the meiosis mechanism. So this is some statistics in our study. The first diagram on the left shows the distribution of patients according to their age. So the majority were in their 30s at the moment of the diagnosis. The second diagram on the right of the slide shows the distribution according to spermogram. They were mostly azoospermic with a percentage of 78%, then oligospermic, 17%, then a low percentage of necrozoakinetospermia. In the last diagram, it's clear that primary hypogonadism is the most frequent versus low percentage for excretory azoospermia. So I'm going to present 5 interesting cases of karyotype in our unit. So these are two images from our structure. A case of clean culture whose karyotype presents 3 gonosomes. This is on the right an hybridization institute that shows 2 red spots of X centromeres and 1 red spot of Y centromere. So in our theory, 92 azoospermic patients had a karyotype. 23% of them had Klinefelter syndrome. 1 patient had chromosomal formula of 47XXY, 46XY. Represents the mosaicism. Another one had a formula 47XXY and 46XY, 45X. And the last one with the formula 47XXY, 46XX. The second case is an XX male. So the fish confirmed the presence of the SRY locus on the X chromosome. We have the image of the PCR product that shows the amplification of the SRY gene, and the subsequent sequencing shows the absence of mutation. The third case is an isochromosome Y. So as you see on the slide, there is an isodecentric chromosome Y. There is 2 centromeres. And in the hybridization institute, we have 2 centromere signals. The fourth case on the left is a translocation between acrocentrics, 13 and 14. And the fifth case on the right is derived from chromosome 16, resulting from translocation between 7th and the 16th autosome. So in this slide, in the left, you see a representation of Y chromosome and its 2 main genes, the SRY on the P arm and the AZF gene under the centromere. So microdeletions of the AZF region are found especially in 5 to 10% of severe oligospermia or azoospermia. This region has a palindrome structure that will promote remodeling and leads to partial deletions of the 3 AZF, A, B, and C loci. So depending on the type of deletion, we will have a different histological phenotype. An AZF deletion leads to a Sertoli cell syndrome with total absence of germ cells in the testicle. So if we have the mutation on AZFB or AZFB plus C, the deletion either results on a Sertoli syndrome or a mutation RS at the spermocyte stage. But in the case of deletion on AZFC, the phenotype is variable from hypospermatogenesis to Sertoli syndrome. It has generally a favorable prognosis comparing to AZF A and B. So the interest of the research of these microdeletions of the Y chromosome is mainly prognostic because only the AZFC deletions will allow to propose the testicular biopsy. So the second interest is to inform the couple that this type of deletion can be transmitted to the male descendants. So this is the AZFC region representation. Concerning partial AZFC deletions, we have three genotypes. We have GRGR, B1, B3, and B2, B3. So genotypes GRGR, genotypes GRGR deletions have an effect on spermatogenesis, which is controversial because it depends a lot on the ethnic origin. These deletions are present in about 3% of fertile men. It is now considered a risk factor for impaired spermatogenesis rather than a cause of azoospermia. As for the other deletions, their role is not clearly defined yet. So in the first image, we see the mapping of the Y chromosome of the different loci explored by the Y chromosome AZF analysis system kit. Among the 91 patients with a normal karyotype, only 23 were tested for AZF microdeletion. No patients had this abnormality in our study. So when the karyotype and the exploration of SRY and AZF genes are negative, we search for the CFTR mutation responsible for cystic fibrosis, especially the congenital bilateral absence of the fast difference in leukocytosis. Its prevalence is 1% per 1,000. 2 genes have been isolated. And our diagnosis strategy is to search for the most frequent variants of the CFTR gene. If negative, we complete the rest of the gene. If all the CFTR gene is negative, so there is no mutation, we look for the gene ADRGR2 mutations by NGS. So in our laboratory, we are searching for these 14 recurrent mutations shown in the table. They are recurrent mostly in North Africa, and we look for them by using a nanopore sequencing, with collaborating with Switzerland team with Professor Abriel. Then we have CGHRI. CGHRI has also a role in male infertility genetic diagnosis. It identifies CMV, which means deletions and duplications. So thanks to this technique, the involvement of the TEX11 gene in male infertility has been discovered. It is to note that few laboratories use CGHRI in the etiology of male infertility. And finally, we have next generation sequencing. I thank on this occasion Professor Ratsby for the detailed and interesting presentation of yesterday. So it allows, in fact, a whole exome sequencing and a whole genome sequencing using gene panels. It identifies founder or recurrent genetic variants in cohorts of patients who present an identical phenotype. 2,300 genes were identified in spermatogenesis, and over than 400 genes are implicated in infertility. So this diagram shows the main genes involved in different stages of sperm development, from the stage of spermatogonia until the stage of spermatozoa. So we have each stage, we have the genes that are implicated. We have a lot of panels for each stage. We should talk here about teratozoospermia, which means the abnormality of the shape of the sperm. So it's implicated in more than half of the cases of male infertility. We have three interesting types. So the first is acephalic spermatozoa syndrome. And the gene implicated is SAN5. Then we have globozoospermia, and the mutation which is implicated is DYP19L2 gene. And finally, macrocephaly sperm, and the mutation implicated is the ORCA-C. So this is the representation of the ORCA-C, which is the Aurora kinase gene. In our theory, 5 patients did not undergo karyotyping in our units. So when we have seen them in consultations, we have prescribed directly the ORCA-C mutation, especially the exon 3. And 2 other patients were referred for isolated polymorphic teratospermia, and 3 patients were referred for OATS with a majority of macrocephalic and multiflagellar spermatozoa. So those 3 patients had an homozygous C144 deletion. We should know that the ORCA-C gene located in the 19q arm region includes a member of Aurora subfamily or serine threonine protein kinase responsible for regulating several meiotic cell cycle events. It is important to maintain proper cellular fluidity. So this mutation in the ORCA-C gene leads to the production of large-headed polyploid multiflagellar spermatozoa, a primary infertility phenotype mainly observed in North Africans. So we conclude that the involvement in the involvement of genetics is great in severe sperm abnormalities. 60% of genes are associated with maturation RS. So the first-line genetic investigations remain unavoidable, and the integration of NGS has enabled 30% more diagnosis. So in our laboratory, we offer just the first-line investigations, and we hope to develop NGS diagnosis in the near future. Thank you for your interest.